My name is Henry Steplin. I'm a P3 student at Florida Agricultural Mechanical University, Pharmacy and Pharmaceutical Sciences. And this is my journal club for evidence-based medicine, fall semester. My general overview of it. My topic was community-acquired pneumonia requiring hospitalization among U.S. children. And it was funded by the Influenza Division of National Center for Immunization and Respiratory Diseases. The reason for this study they did was the incidence estimates of hospitalization of community-acquired pneumonia among children in the United States that are based on prospective data collection were limited, and updated estimates of pneumonia that has been confirmed radiologically, supporting evidence of that the patient actually has pneumonia, was needed with current laboratory diagnostic testing to basically prove the patient has pneumonia. The objective is to update the incidence of hospitalization for community-acquired pneumonia among children, confirmed radiologically. Sorry about that. The trial design was a prospective, multi-center, population-based active surveillance study. It was actually done in 3 different cities, 3 different children's hospitals, 1 children's hospital, and it was the Lee Bonru Children's Hospital in Memphis, the Monroe Carrell Junior Children's Hospital in Vanderbilt, Nashville, and the Primary Children's Hospital in Salt Lake City. Study protocol was approved by the Institutional Review Board at each institution, and also in consideration with the CDC. Written informed consent was obtained from the parents and caregivers before enrollment, with children providing assessment when age appropriate. Inclusions of this topic. The patients must be younger than 18-year-old, admitted to one of the 3 study hospitals, and resided in one of the 22 counties in the study catchment area, so in the surrounding areas of the hospital. Had evidence of acute infection, had evidence of acute respiratory illness, had evidence consistent of with pneumonia as assessed by means of chest radiology within 72 hours before or after admission. Exclusions. Children were excluded if they had been hospitalized previously, have been already hospitalized, recently within the last 7 days, or within the last 90 days, if immunosuppressed, had been enrolled in an EPIC study within the previous 28 days, resided in an extended care facility. They also excluded if they had alternative diagnosis of respiratory disorder. Newborns who never left the hospital were excluded. Tracheostomy tubes had cystic fibrosis or cancer treatment within the previous 90 days. Also, if there was immunosuppressant, had a low CD4 count of 200. There in total enrolled, there was 2,638 enrolled subjects younger than 18-year-old requiring hospitalization in these 3 hospitals. The primary endpoint was they did not have radiographic evidence of pneumonia, so they did not show positive infiltrates or butterfly effects or the different evidence supporting pneumonia. Secondary endpoint was the parents or the caregiver had withdrawal consent of the enrolled patient. Follow-up, children and the caregivers were asked to return 3 to 10 weeks after enrollment, so 3 to 10 weeks after the hospital visit, for follow-up interview and convalescent phase serum collection. So it's going to do another collection of the serum to see what bacteria, if any, were present. The duration of this trial was from January 2010 through June 2012. It had a total population of 2,358 of whom had radiographic evidence of pneumonia. Excuse me. And this was out of the enrolled 3,803 eligible children. The arms of this experiment, 2,358 of whom had radiographic evidence of pneumonia, were conducted as active population-based surveillance for community-acquired pneumonia requiring hospitalization among children younger than 18-year-old in 3 other hospitals of Memphis, Nashville, and Salt Lake City. Statistical analysis played a big part in this because it was before is why this was the reason for this research, because it was up on the admission of hospitalization and the endpoint effect that, and also market share diagnostic discharge diagnostic codes was the reason for it was a 22% 22 cases per 10,000 for pneumonia, but here we were actually able to get a more precise with this experiment. And the statistical analysis of it, annual incident rates were calculated from July 1st to 2010 and 2010 to June 30th, 2011, and also from July 1st, 2011 to June 30th, 2012. For the calculation of incident rates, the number of enrolled children with radiographic evidence of pneumonia was adjusted according to the age group. For the proportion of eligible children enrolled at each study site and the proportion of admissions of children for pneumonia to study hospitals in that attachment area, market share. And the adjustment number was then divided by the U.S. Census population estimated in the area for the corresponding year. So just making our small numbers relate to the big numbers in that population. That's what they were doing. The market share was based upon discharge diagnosis code and were calculated pathogen-specific rates for pathogens detected in more than 1% of children by multiplying the total incidence of pneumonia while the proportion of each pathogen detected among each children with radiographic evidence of pneumonia who had specimens available for the detection of both bacteria and viral pathogens. To calculate a 95% confidence interval, the true method with 10,000 samples were used. Okay. Baseline characteristics, we have enrolled 2,638 of 3,803 eligible children, 2,358 of whom had radiographic evidence, so they were positive enrollees, with a median age of 2, ranging from 1 to 6, mainly for that medium age. And for the end of primary endpoint, we had 270 incidents that were not included because they had no evidence of the radiographic pneumonia. Also, we had secondary endpoint 10%. 10 cases were withdrawn due to parent consent being withdrawn. Adverse events happened with the controlled subjects. Because of the controlled subjects, we had 726 controlled subjects that could not be reached for follow-up, and of those, we had 125 that could not be reached for follow-up. 80 had fever or respiratory symptoms after surgery. These children were excluded from the analysis. Okay, the author conclusions. In conclusion, the burden of the hospital of the community-acquired pneumonia requiring hospitalization was highest among children younger than 5 years old with respiratory viruses frequently detected. Effective antiviral vaccines and treatments, particularly with RSV infection, could have a mitigating effect on pneumonia in children. The low prevalence of detection of bacteria pathogens probably reflects both the effectiveness in bacteria conjugate vaccines and relatively insensitive diagnostic tests. The burden of community-acquired pneumonia in children was associated with multiple different and co-detected pathogens, underscoring a needed for enhancement sensitivities and expensive and rapid diagnostic tests to adequately identify pneumonia pathogens. My criteria, my thing was it was a nice sample size, and definitely in different areas as it conducted. And what I liked about the study was that it was in different areas, and it had the expertise for each hospital within the hospital to enroll that study, so you didn't have to send off labs and stuff to continue the study. It actually became a routine part of that staff's daily evaluation and other protocols within that 2-year period for us to actually get some more concrete numbers. It's more concrete within that area, but we have more concrete numbers with positive information supporting it with the pediatric specialists of radiograph diagnosing the pneumonia rather than just on the per case analysis from the diagnostic code and the prescriptions used, which would seem to be a higher incidence, when those cases were more higher incidence due to the fact that they were underdiagnosed or they were overdiagnosed and didn't need some of the medication, or didn't particularly have pneumonia, probably a severe cold, or the pathogen just wasn't present after follow-up or upon admission, discharge. In my opinion, the experiment was well performed and consistent with its results. Before, like I said, there was no analytical data, but with this here, we was able to come up with some provide some analytical data behind the hospitalization among children below the age of 18. Thank you.